So the next skill that we're going to talk about is ostomy care. We're taking care of a patient's ostomy that's been surgically placed. So first, what is an ostomy? Ostomies are artificial openings into an organ system that's created during surgery. So in this case, it's the bowel. Part of the bowel is pulled through to the surface of the skin, and we have diverted the way that stool moves through the body naturally. This can be either temporary or permanent, depending on the location and the etiology of the problem that required the ostomy to be placed. Two main areas where ostomies are placed on patients. One is the ileum, which we would call an ileostomy. The other is the colon or large intestine, where we would call a colostomy. Super important to keep in mind that the consistency of stool that is produced will change depending on exactly what level of the bowel is the ostomy is made. So in ileostomy, we would expect very liquid stool, like 100% liquid, maybe a few like sediment chunks, but this stuff is gonna be liquid. It may also be not like stool colored, it could be green, depending on how high up, how close to the bile duct it may be. For the colon, if patients have an ascending colostomy, it would be more liquid than a transverse or descending colostomy. So depending on where in the colon they're placing the ostomy is really going to change what type of stool is produced by it. 3 types of ostomies. This woman's like a champion of ostomy. She works for the National Ostomy Foundation. She rocks. She's also very crafty. Highly recommend this video. She goes through all the different types of ostomies in a lovely visual way. I'll put the link down in the description for this one, for all the videos in this presentation. Here are the kinds that she's going to go over. So one is a loop ostomy, where surgically an incision is made on the abdomen. The surgeon pulls through a loop of bowel, kind of fillets it open so it's not completely cut, but most of it is cut, but we have the 2 lumens exposed, right? This is usually done in an emergency. This is it's the most temporary of all the different types of ostomies. Usually, if there's a stabilizer put in place, it's only there for about a week, and then the ostomy is kind of in place, and we're able to remove that stabilizer. But there are 2 openings to a loop ostomy. There is one opening where stool will be produced, and one opening where mucus will be produced, because that's the distal end of the ostomy. Stool hasn't made it that far. But because the bowel, it's all mucous membrane, there will still be mucus produced. So there may be drainage from both stomas, but one of the stomas will be draining stool, the other will just be some like liquid mucus content. Next is an endostomy, meaning we're doing this ostomy at the distal end of the colon, or whatever level of bowel is remaining in our patient. So these can either be permanent or temporary, but these are definitely a longer term solution than like our loop ostomies. How long a patient is going to have their ostomy really depends on why they have the ostomy in the first place. Patients with Crohn's disease, ulcerative colitis, they may have these for short periods of time or long periods of time. It all depends on the severity of their exacerbation. If they have something like a colorectal cancer, where part of their bowel had to be surgically removed because of that, I hesitate to say contaminated tissue, but because they have cancerous cells in that section of bowel, it might be more permanent. For patients who have other diseases where they're going to flare up and then go into remission, more temporary. These are done as distal in the bowel as possible. So usually these are almost all in the descending or sigmoid colon whenever possible. If there's a section of bowel that remains in place, so this person, as they've drawn here, had a colectomy, meaning a partial removal of their colon, of their sigmoid colon. So the endostomy is part of the descending colon. This part of their rectum that has been left in place is in situ, meaning left in place. It's called a Hartmann's pouch. The idea here for leaving part of their bowel in place is that at a future date, the surgeon could re-anastomose or re-sew that end ostomy back to that remaining bowel, and the person could then defecate normally. If that's not possible, then this will be a permanent ostomy. So then we get to our double barrel ostomies. These are typically very temporary because you can see like the goal here is to eventually, connect these back together, just to re-anastomose them so that the patient can have normal bowel function. These are the least common type also. I've actually never seen these in practice. Usually the type of ostomy that I see in practice, I think I've seen one double barrel, but usually it's an end ostomy. This kind where there's only one stoma that comes through the skin. But a double barrel, this is the distal and proximal end. Both are pulled through the skin. So there's two different ostomies. One is going to be our stool producing. So the proximal end is going to produce stool. The distal end is non-functional. It's going to be producing some mucus. But both of them we need to dress with an ostomy bag to collect that stool content or that mucus content from our patient. Other things that can be done, gastrointestinal surgeons are highly creative and they make all kinds of pockets and pouches in patients in order to try and divert the bowel and help to give them as much continence of their bowels as possible. Things like ilioanal pouch, which is where they attach the small intestine to the rectum. It's kind of like an internal ileostomy type of thing, but there is a level of continence that these patients have because it is attached to the rectum. They do get a sensation that they need to defecate. A Coke pouch, which is it's kind of a Lego version of making a reservoir where stool can be collected and then can be drained at regular intervals. So there's an element of continence to these. Also, these MACE procedures where they take the appendix and make that the ostomy. But because of the dilation and the size of the appendix relative to the colon or to the rest of the bowel, there is an element of continence that patients can get from these. So all of these different creative methods, they're pretty non-traditional. They're designed to help give patients an element of continence to their bowel diversion. Because all of our ostomies, regardless of where they are or what type, patients are going to be incontinent of stool through that ostomy, which is a big deal for patients who are around body image. So we do always want to try and promote continence as much as possible and help them to feel comfortable with their body despite having some pretty serious surgical interventions done. So care of a patient with an ostomy. Here's the thing to note. That ostomy bag is not your friend. It is something that will not look out for your best interest. It will try to ruin your day as many times as possible. So when you're dealing with a patient with an ostomy bag, what these are is they're almost like little sandwich-sized bags that are attached to that opening. So they don't hold that much. So when these things fill with stool or gas, because it's the bowel, so it's producing both stool and gas, they need to be emptied. Rule of thumb, never wait till they're like full. By the time it's full, you are in the danger zone. This thing will blow up on you. About a third full is like entering danger zone territory. If you go in and assess a patient and it's about a third full, just go and empty it. That way you're saving yourself from the trauma and your patient from the trauma of having a bag of stool explode all over their abdomen, which is really, really unpleasant. The appliance is like a disc, an adhesive disc that goes around the stoma to help seal the bag to the skin. This needs to be changed every 3 to 5 days or as needed for leaking. But we do want to try and keep these things in place for as long as possible because the adhesive on there is no joke. So if we're constantly peeling it off and putting a new one back on, we're going to damage the skin tissue around that stoma, and we don't want to do that. We want to try and keep that skin around the stoma as healthy as possible, meaning don't tear tape off of it as much as you can. So we really, really, really do want to try and promote the life of that appliance for as long as possible. Stool is very acidic, so also those devices, the appliance, when it comes, the opening is about the size of your little finger. But everybody's stoma is different. So there's always you have to custom cut the internal area of the appliance to match the size and shape of the patient's stoma. So every one of them is a custom fit. If we cut those a little too large, it's a problem because the stool content is very acidic. So it will cause tissue damage to any exposed skin tissue where that appliance hasn't protected the skin. So this needs to be a custom fit each time we apply one of these appliances. Yeah. So here's a stoma. So if we were to cut an appliance for this stoma, what we'd be cutting is a disc that's going to kind of perfectly outline this area, protecting all this peristomal skin. Right? That's our goal. This is a person who's had an ill-fitting appliance placed, and you can see kind of the rashy tissue from where that adhesive has been peeled off multiple times. So it's almost like a diaper rash kind of situation going on right here. You can almost kind of see the outline of where that appliance was, kind of right here. So that's what's going on. When we document, this is also what the stoma should look like. This is a very healthy looking stoma. So nice and pink, moist, looks great. No signs and symptoms of drainage or infection around the insertion site. That is a normal looking stoma. So when we do our documentation, we're going to follow the same process we do for our assessment. So look, listen, feel. That's the way we do it. So inspect the appearance of the stoma. It should be nice and pink and like this, a little bit soft looking and moist. Assess the peristomal skin. We don't want to see any excoriation or erythema like we do here. And the appearance of the stool. So what color is it? What consistency is super important because we do want to make sure that it's appropriate for the level of bowel diversion that the patient has. Then we want to palpate around the stoma. Don't poke the stoma itself. That's an internal organ, and we don't want to poke internal organs. I don't know what the literature says about doing that, but it seems like a bad idea. So don't poke internal organs. But the skin around here, we want to poke that and look for any induration, meaning thickening of the skin. It's kind of like when you get like a bruise or a cut and you can feel that inflammation around there. It's kind of thicker than normal skin. That's induration. I would bet that this is indurated because there's signs of an inflammatory response going on. So that's what we're looking for when we palpate around the skin. Also for heat, swelling, those sorts of things. Then we want to listen. So don't stick your stethoscope on an ostomy too. That's also a good way to get poop on it. And like, don't stick your stethoscope on internal organs. Also don't know what the literature is on that, but I'm sure it's bad. So don't do that. But we're gonna listen for our bowel sounds. So quadrants, same as always. Depending on the level of their ostomy, there may or may not be bowel sounds in all 4 quadrants. The important thing is to note, is it the same or different than it was during a previous assessment? So that's a key thing there. And then what you did about it. So if you did a procedure, always document that. If all you did was empty it, just say ostomy emptied. Great, moving on. If you changed the whole appliance, the part that goes on their skin and the bag, document that. Say, what did you dress it with? And how did the patient tolerate that procedure? 2 things we always want to do. Say what we did and how our patient tolerated it. 2 big things. People are going to be living with these ostomies as an outpatient. So it's super important that as soon as we start taking care of their ostomy, they start getting exposed to how to take care of their ostomy also. So teaching starts immediately after surgery, because this is how people are going to be out there in the world living their normal lives with an ostomy bag. So we need to be able to counsel them about wearing elastic pants so that they can help to kind of keep that ostomy bag secured against their body. As you can see, there's no way we would know that this patient has an ostomy, and that's pretty normal. Kids can have ostomies. It's pretty common for kids to have ostomies if they have severe like GI congenital issues, and they can tolerate them really well. Obviously, this kid is not going to be awesome and crushing the teaching side of it, but this guy sure can. So as soon as they're able to start participating, we want to start doing that. These fancy ladies, like, she's shredded and she's got an ostomy. She's crushing it. Working on your tan, getting all fancy. People are going to be living with these things. So we want to prepare them for that and also let them know that there are support groups to help them to adapt to living with these new medical devices as much as possible. So the nursing diagnoses we want to look at, impaired body image is a big one. We do want to let them know there's going to be changes and help to normalize that experience for our patients as much as we can. Teach them knowledge deficits around teaching them how to handle these things, and then what support things to look for. So the United Ostomy Association is a big one. The National Foundation of Ileitis and Colitis also have a lot of resources for colostomy patients. And I got to tell you, on YouTube, there are a lot of content creators with ostomies who just talk about their life with an ostomy. They show people how they take a shower with their ostomy. It's all like YouTube appropriate. But they talk about how they go to the grocery store, how they go on a road trip with an ostomy, all kinds of things. So definitely refer patients to whatever resources are available to them and whatever is going to be the most pertinent to their life. That's it for ostomies.